Okay, so everyone, first of all, welcome to the clinical webinar for December. We've pulled together tonight's clinical webinar loosely focused around primary care, which will become evident as we go through the presentations. So just to give you all a reminder, actually, that we're running a series of webinars. So we're running research webinars, clinical webinars, and implementation webinars. All the details for future webinars are published on our website. And they are free to attend, so please join, certainly if you're interested in the particular areas. And without further ado, I'm going to hand over to David. So David Rocha, who's from San Antonio in the US, but I'm sure David will introduce himself. So David, I'm going to stop sharing and then hand over the screen to you. So you should be able to share screen on the bottom.
Okay, let me know if you can see the screen.
Yeah, we can see the screen. All looks good.
Okay, well, good evening, good afternoon, everyone, wherever you're located. My name is David Rocha, and I will be discussing how we were focusing on SNOMED CT as an important terminology for primary care. And just to make acknowledgements, I would like to thank Ian, Green, Peter, and of course the clinical engagement team for this opportunity. So just to give a little introduction on primary care, currently there's a lot of shifting from value-based care, and now with COVID-19, there's been more of a shift with telemedicine because it's definitely transformed the way that we do things. And in terms of data capture, we're having to see the need of implementing care plans as a resource. So it's very helpful for not just data capture, but also for as a frame of reference. And providers and clinicians truly have an opportunity to prioritize which elements of the care plan are truly essential. So whether it's for a patient with alcoholic cirrhosis, do they have a current PT-INR level? Have they been screened for alcoholism and so forth? All of that's very helpful for the clinician for primary care. And primary care clinicians want a true solution to streamline quality. And that's why I believe that SNOMED CT truly is the answer to optimal documentation for structured data capturing. And just to give a little more about myself, so I'm from San Antonio, Texas, in the United States, and I work closely with a primary care physician and also with an accountable care organization. So just to give a quick preview of what I'll be discussing, I'll be going over primary care and how it relates to quality data capture, not just for managed services organizations, but also how it relates to accountable care organizations, and then how the importance of custom templates help to the using SNOMED CT as the foundation for us, and how that resulted in viewing the point of care analytics and also for population health. And then later I'll give some examples of some of the care plans that we introduced, and then give some 2020 updates on how we did that for extremity studies, behavioral health, and also with COVID-19. So by using custom templates, it was a short-term solution for us. It helped to tailor to the provider's needs for quality measures, for structured data capture, and also for care plans, because for us, quality measures can be a very daunting task for not just the administrators, but also for the clinical staff. And that's why we saw the need to do patient care plans to actually take care of the patient, not just to fulfill a gap or fulfill a check mark off a measure. And we were able to modify these care plan templates to match current clinical guidelines and standards. So whether it was for hepatic failure, whether it was for asthma guidelines, and so forth. And also for the creation of new content with SNOMED CT. SNOMED is very selective and focused on, do these new concepts that are introduced align with international guidelines? So that's why we saw that need. And lastly, that we saw that these custom templates provided a streamlined solution for insurance reporting, for quality documentation, and to help with improvement and outcomes and cost. So this is an example of how we track the measures for Medicare age patients. So for the elderly who are 65 and over, we're looking at certain things. One of the measures that we look at is for the breast cancer screening, the mammogram. We're monitoring if the patient completed such testing and what was the result. So all of this is being monitored from the health organization, from the managed services, and also from the insurance side. So it's from multiple angles. And one thing that I was seeing was, how can I use SNOMED CT as the anchor to show the data and to make it easier for software engineers and the population health vendors to look for it. So that's why I was looking at the completion and also whether it was normal or abnormal. The other screening that we look at is the colonoscopy, which is the colorectal cancer screening measure. It's one of the offerings that we recommend those patients who are elderly to get the test done within that age range. And below you can see the other examples of the fecal occult blood screening, or now that they have the fecal immunochemical DNA testing. So there's different options for those patients. So on our end, we were wanting to see, how do we use SNOMED CT for each of those items? So whether it's the procedure and what was the result, and also the data service. For the other insurance plans, we look at some of the same measures, but one difference is for the activities of daily living. For the elderly patients, we're having to look at what can the patient do on their own independently, or what does the patient need assistance on? So granted, for someone who is bedridden, they can't do a lot of these activities without assistance from a caregiver. So one thing that I was looking at was, how do I use SNOMED CT for this? So I was able to look through the browser and find a lot of the associated findings that relate to the activities of daily living. And this is one example here, the grooming for independent or dependent on assistance. And this slide kind of shows how I created the template. So looking at the individual items, having SNOMED CT in the background for data capture, and seeing what was the result. Was it normal or abnormal with the data service? So as a result of doing this, this was very helpful for us to have a point of care analytics view. So whether it was an advantaged patient, an elderly patient, whether it was someone middle-aged or a younger patient, this was helpful to have these quality measure templates that we were creating to display what was important and vital to the patient, whether it was labs, procedure findings, and also the education counseling that the provider was giving to the patient. Was the patient compliant? Were they non-compliant? Were they going with the diet recommendations by the primary care physician, and so forth? So this was very essential to us because it helps for the creation of our care plans and showing the patient what's recommended for them in their disease state. So I put on the bottom a couple of examples, one for insulin administration and two other ones for glucose monitoring and blood pressure monitoring, because I wanted to go the extra step than just the quality measure and see how are we tracking the counseling that we're giving to these patients. And the other example is for population health analytics. We were able to query by primary insurance, and then related to SNOMED CT, we were able to query by disease. So whether it was all the patients who have congestive heart failure, the patients who have diabetes or COPD, having SNOMED CT as a reference was very helpful to us. And then the other example given on diabetes, the entry for which patients had a hemoglobin A1C less than 9, and also the patients who had the diabetic eye exam. So these were the elements that the care plans that we created we were encountering. So the primary care lead and myself were looking at how to create these care plans that aligned with the current clinical guidelines. And we came across 5 essential items. So the first one is for medications. We're looking at what class is the patient on. Do they have a current allergy, hypersensitivity, or an adverse reaction to those classes? So whether like for a hypertensive patient, are they allergic to the ACE inhibitor or the angiotensin receptor blocker? Going into some of those reactions and hypersensitivities is better to document with SNOMED CT because it's a lot more granular and finite. And then also into the referrals. For those patients who have atrial fibrillation, did we send them out to a cardiologist? Were they refusing the referral? That's been something that we've been looking at. And with SNOMED CT, there are identifiers for that. Did the patient decline the recommended referral to the specialist? And being in a primary care space, that one was important to us to see the patient's compliance and their disease progression. Were they improving in their disease state? And the other items here, the lab tests, seeing how the patients were doing with their essential lab results related to the diseases, the procedures that are being done, and then also the health education counseling. So this is one example that I'd like to show. This one's for congestive heart failure. So this care plan, I just included some of the essential items, and this was drawn from the 2 clinical guidelines from the United States. One is from the American College of Cardiology, and also from the American Heart Association. So the first item here is related to the procedures, is the echocardiogram, which is the ultrasound of the heart. So here we're tracking the patient's current ejection fraction. How is their heart functioning over time? The other one that we're monitoring for these patients with CHF is the medication adherence, and also the certain type of medication. So that's what I mentioned here, the cardioselective beta blockers. Is the patient currently on carvedilol or metoprolol succinate? Or do we know that the patient has a current allergy or reaction to these specific medications? And that's why we use SNOMED CT as a reference here, going into, we could document with the identifier which allergy or hypersensitivity that we're having. And then also the New York Heart Association class of heart failure. With SNOMED CT, we're able to document further by mentioning that. And then as a result, the combination of having the ejection fraction tracking with the medication adherence, it helped to reduce repeated hospital visits. So being in a primary care and working with other managed services organizations and an accountable care organization, that is what we look at, not just the patient's quality. Are they completing their procedures or the preventative medicine items, but are they saving the insurance? I mean, are they reducing costs? Because that's one of the points of being in a primary care facility for us, is to make sure we're taking care of the patient and trying to reduce any unnecessary readmissions. So the other disease I want to mention here is for chronic obstructive pulmonary disease. We did the same thing with the care plan and utilizing the gold standard for COPD. So one important procedure that we do for these patients is the spirometry testing. So this is the pulmonary function test. So we're looking at how is the patient breathing before and after applying the inhaled corticosteroid, the short-acting beta-agonist. So how did they do with the rescue inhaler? So these are the 3 ratios listed here, and we look at them pre and post. And with SNOMED CT, we were able to put the identifiers for each of them and also classify the severity, which is nice because that's not available with ICD-10. And the same thing, us tracking the spirometry percentages with our documentation for COPD helped to reduce the excess emergency room and hospitalizations. And then these are some more items that we do, the COPD assessment test. So we document the procedure with the score, and then also the education that we give to the patients for managing their respiratory health. So this is the example from the software of how we document that. Some of the new screenings that we're doing is essential for us because we're being monitored by several insurance plans and also for the population range. So one here is for the vascular screening. So one important test for that is the ankle brachial index. And this is helping to rule out peripheral vascular disease. So for the primary care clinicians that are on this call, or for those who are administrators, this is becoming an important test to do in the primary care offices. So we're able to document, did the patient do the ABI? What was the actual result? And documenting which dorsalis pedis was being done. So that's why I was including some examples here that we were doing with the identifiers. The other screening I wanted to mention was for neuropathy. We're doing the sensory nerve conduction studies to help see if the patient has any possible polyneuropathy or autonomic neuropathy. So this is helpful for not just the elderly, but also for the diabetic patients. And the same thing, we're documenting the observables and also the procedures. And I forgot to add on here the observables for the velocity and the amplitude for sensory nerve conduction. And then what was the other update for our organization? Well, one, we decided to do a behavioral health model. So integrating behavioral health between the primary care facility and also the access to the psychiatrist. Because for the other primary care clinicians on this call, you can imagine that it's very hard to get access to a psychiatrist right now. So something that we've been doing as an organization is partnering up with licensed clinical social workers. So having them assess the patient, and they have more access to the practitioners and to the clinicians to help filter who really needs to see the psychiatrist quicker. And utilizing SNOMED CT, we were seeing how that was helpful for us. So the first example here is for depression. For our clinic, we utilize the Patient Health Questionnaire 9. So we use the procedure and the observable. And with SNOMED CT, we were able to document the specificities for moderately severe and minimal depression. And those are in SNOMED CT. And also was the patient being seen by the social worker and the referral to the psychiatrist. The other two disorders I wanted to mention, one was for anxiety, especially with the COVID-19 season. We've been seeing a lot of cases of patients who have anxiety or increased, where we're doing telemedicine to help improve their state, even if they're not able to travel or to go around. So the screenings that we use is the generalized anxiety disorder 7-item assessment scale, and also the observable entity for the screening. And the last one that's helpful for us is did the patient decline the recommended screen? And then the last disorder related to behavioral health that we look at is for bipolar disorder. The social workers and the behavioral health team, they look at the mood disorder questionnaire assessment and the score. And we've been using SNOMED CT for it as a reference. So what were the outcomes for us? Well, one, it improved our financial reimbursement. So the clinician that I work for, Dr. Rocha, was ranked #1 in quality among the San Antonio clinics in the accountable care organization we're a part of for 3 years, 2015, 2017, and 2019. And he was also a recipient of the Humana Gold Star rating for the improved outcomes and quality. And we were thankful to having SNOMED CT help being that reference for us. The other outcome was that it improved our medical risk score. So in the United States, we're big on risk adjustment, so diagnosing the patient as specific as possible. And with ICD-10, there are plenty of disorders that are not as specific or granular that could be captured. So we were mentioning the items here for stable angina and clinically significant macular edema. And yes, now more the electronic medical record softwares are utilizing SNOMED CT for the problem list. What was the other advantage? Well, this is more of an individual advantage. I was able to author content. So learning about SNOMED CT online, I took the e-learning courses in the foundation course, the implementation course, and the authoring level 1 course that SNOMED CT offers. And after learning about the terminology, I was able to send content requests to the U.S. National Library of Medicine, which is the National Release Center for the U.S. And these were some of the examples of content that got added. So one here is the Wong-Baker Faces pain assessment scale, which is utilized in many hospitals. And then going back to depression, I submitted content for the Patient Health Questionnaire 9 score and the minimal and moderately severe depression. So like I mentioned before, this is being monitored by every managed care organization in the US and for accountable care organizations. They're really tracking how did the patient do in terms of depression year to year. And then some other examples, one is the Montreal Cognitive Assessment for dementia, and then the Chronic Care Management Minutes. This is more of an observable that we track for the Medicare population. And then also the content that applies to behavioral health, the opioid risk tool, to see if we utilize that tool and the identifier to help see if the patient should be on non-opioid alternatives. And then some of the other material here can apply to insulin pumps and glucose meters, which is the basal insulin infusion rate and the bolus insulin infusion rate. And then also I became a member of the Diabetes Clinical Reference Group that Paul Amos and Kathy Richardson lead. And after being in that group for a while, which has been, it's been a great experience, I found a few concepts that were not currently in SNOMED CT. So I submitted these to the National Release Center for Inclusion. And the two mentioned here are for centrally involved macular edema and non-centrally involved. And then just to give a little preview here, with COVID-19, our organization saw the need to add some concepts to SNOMED CT for social distancing and some of the items that relate to what does the provider recommend for the patient to do. So these concepts here will be added to the official release in 2021. I know right now it's in the daily build. So the concepts here are for, is the subject performing social distancing? was education given about social distancing, and was the subject advised to avoid crowds or to avoid foreign travel? And this all relates to the current CDC recommendations. In terms of benefits of SNOMED CT for the healthcare industry, I believe SNOMED CT is the most accurate clinical terminology to track events and identifiers in and across databases. And these are two examples. One is for history of surgeries and radiology findings. And a big area for primary care is also for assessment scales. And also SNOMED CT terms and identifiers were created by doctors with all patients in mind. In terms of the future of SNOMED CT, I believe that more software will import SNOMED CT, whether it's through release files and now also with APIs with like Snowstorm that SNOMED created, into databases to query by quality measures, and also to continue using structured data with SNOMED CT identifiers behind or inside the options given here, whether it's checkboxes or radio buttons. So I like to emphasize this point to the health IT professionals who work in primary care, that you have an opportunity to help improve the documentation for that and for care plans. So just to give a little summary on how our organization focused on primary care, we were able to track care plan elements closer to real time using SNOMED CT as the base. We were able to link the codes and identifiers to the dates of service. We were able to analyze point of care and population health analytics as an internal organization, and also for the population health vendors that we encounter, and for the managed care organizations that we have a relationship with, not just for the prevention, not just for quality, but also for care plans and taking care of the patient. And then I gave some updates on how we added behavioral health and utilizing SNOMED CT to help with documentation for anxiety, depression, and bipolar disorder, and also the future concepts for COVID-19 in terms of social distancing. And the last part was authoring content with the national request system. So I just wanted to say one last point, that it's very important for everyone on this call to stay engaged with SNOMED CT. So whether it is through clinical reference groups, the e-learning courses, or the clinical engagement team on the call, like Jane Miller, Ian Charles for Europe, and Peter Hendler in the US. They're amazing resources, and just stay engaged. And that includes my presentation.
So thank you, David. And thank you for the vote of confidence in us all. We have some questions in the chat box, but I want to go straight into the next presentation, and then we'll pull all the questions together at the end, which is easier to manage. So I'm going to hand over the virtual floor anyway to Denise Downs. So Denise is I won't say an old colleague. She's not old, but a past colleague of mine. We worked together in the UK a while ago. But Denise is going to talk about SNOMED in general practice, and most of you will be aware that it's mandated for use in the UK. And I'm going to hand over the floor to Denise and let you introduce yourself, Denise.
Thank you, Ian. Can I just double check that you can see my slides?
Yes, we can.
Brilliant, thank you. Okay, so thanks very much for inviting me. As Ian said, I'm going to go through our journey really to get SNOMED CT in general practice. Just to emphasise that although I come from the UK, it is for England. We do work very closely with the other 3 UK countries, but healthcare in the UK is devolved, and England has been pushing it quite heavily. The other 3 countries are going over to SNOMED, but they're a little bit behind where we are in England at the moment. So just a quick background. I actually come from a different perspective. So my career has all been in IT, and actually I spent a significant number of years working in universities and secondments in companies implementing IT systems, both nationally and internationally. But in 2009, for various reasons, I decided to take a significant shift and went to work in the NHS. So I've now been in terminology for about 11 years, and a lot of the role has been education, training, supporting suppliers so that they could implement SNOMED within their systems, but also we do quite a lot of work with the professional bodies, because obviously they have significant influence over our clinical professions in England. So in 2016, we began the journey of migrating our GP systems over to SNOMED. And I'm going to give you a bit of background as to where we came from, what approach did we do to get onto SNOMED off the previous coding scheme, and some lessons learned. So it's probably worth saying that our GPs have had electronic systems for record keeping for a significant number of years. The systems are quite sophisticated and quite well developed. They can create their own templates. Their suppliers will give them templates that tries to ensure that their data entry conforms to national guidelines. Our NICE guidelines, and a number of the suppliers will produce templates and business rules to support the clinicians in their recording to make sure that they comply to those guidelines. So we actually have got significant functionality in our GP systems. The challenge for us was that it wasn't in SNOMED. And really, we had two terminologies. We had Read version 2 and we had CTV3. Actually, CTV3 evolved from Read version 2, and SNOMED, a lot of its initial content came from CTV3, but of course it had evolved significantly over time by the time we'd got to 2016. We had some issues that if I, as a patient, moved house and my records went with me, we transfer them electronically. But if you were in a practice that used the system that had CTV3 and you moved to a practice where it had Read version 2, then actually some of the data about you that was coded, we couldn't put it into Read version 2, and it just, we call it degrade to text. So the challenge there is you had some information about you that a GP felt needed to be put in a structured way, in a coded way, and all of a sudden it got degraded to text. 3 of our suppliers had already moved terminologies before. So prior to Read version 2, we'd had something called 4-byte read, and actually prior to 4-byte read, we had something called OXMIS codes. So our suppliers were quite vocal about what they were prepared to do and what they weren't prepared to do. But that was a great bonus for us in a way, because they were really quite firm about how they needed to move. And they were quite picking up some of the issues. Some of our challenges was all our national specifications. So if we wanted to look at our asthma patients, or we monitor on quite a lot of different disorders, and we actually have to produce we did have to produce those specifications in both Read and CTV3. And what we did was we publish mapping tables that take, if you've got a Read version 2 code, it can map to CTV3, but also as we could go from CTV3 to Read version 2. As I say, sometimes the map from CTV3 to Read version 2, there wasn't a code to go to. So all our GP system suppliers are under a national contract, which meant we had some leverage to say, you have to move off the Read codes and you have to go to SNOMED. We just have 4 main EPR suppliers, but we also have a number of subsidiary suppliers who produce things like templates, decision support tools, template recording on handheld devices. And so we had to liaise with all them as well. And we had to, the challenge of managing this whole huge estate off existing terminologies onto a new terminology was quite a challenge. As Ian said at the beginning, we do have a mandate. So from the Department of Health, there actually is a mandate, and actually it came into contracts as well. So we had quite a lot of leverage to say this is what you were going to do. One of our other benefits in convincing GPs that this was a good thing to do was that a number of our secondary care providers had actually been using SNOMED for a number of years. They'd already got EPR systems that used SNOMED, probably not for as many data items as we have in general practice, but there was already some belief that it's been out there and it's been used for quite a while. We also have a big push on interoperability in England, that we want to take some of the burden of recording away from clinicians where they're repeatedly re-entering the same data, or they get a discharge letter that came from a system that might have already coded it and they're having to retype it in because they weren't on SNOMED. So there were a lot of drivers to support us in making this move. So I was trying to make this a bit Christmassy, but I think the belief that this was the right thing to do, and our professional body for GPs supported us very heavily, was sort of an underpinning thing all the way through. However hard it was, we had to be able to do it. So we literally had a really small project at the centre, and it was our responsibility to drive the change, to keep communications going, and to provide knowledge to people who weren't sure on what needed to be done, or maybe didn't have an understanding of SNOMED. If you were an organisation or a service that had previously been using the read codes, then inevitably you were going to be impacted by this. But basically you needed to lead your changes, and we had quite a few interesting conversations as a result of this, and trying to convince people that I could not come in and convert their service because they were the ones with all the knowledge. What I could do was help them to understand SNOMED and work with them was quite a challenge. And actually all that was funded was the central project, so they had to do that within their own development budgets and everything. So for example, our GPs are actually paid based on a system that queries their EPR, and that was all written in the read codes, and that had to be converted over to SNOMED. And that's probably one of the services that we worked with one of the most, but basically we converted the whole of the GP payment system over to work on SNOMED. But things like our public health monitoring, again, we did lots of training for them, and they had to convert things like vaccinations and the guidance that they gave over to SNOMED. All the training and all the support workshops that we did for free, whether it was a NHS organisation or whether it was a private organisation providing support to the NHS. All the training on SNOMED we did centrally. We did either via group workshops, and in a number of cases we did some one-to-ones for some companies, and all that was provided free. We worked really closely with all the 4 GP suppliers, and if they had any issues about how things were going to be done, then they actually raised it with us, and we literally got all 4 GP suppliers in a room together at the same time and literally hammered out how we were going to do some of these things. We also had an expert reference group of GPs that in effect was appointed for us by our British Medical Association and our Royal College of GPs. So, and the GPs who were appointed to that expert reference group would give updates every meeting that we have something called the Joint GP IT Committee, which is the IT representatives from both those bodies. And literally all the way through the project, there was an update on SNOMED to every single one of those meetings. And the benefit for us was it was given by the GPs. I also would go along, but it definitely was a joint presentation, which helped keep the GPs on board with us. And actually, we had a point partway through where one of the suppliers was considerably behind where they'd promised they would be. And actually, the professional body asked them to attend their meeting to account for why were they so behind because of the problems it was going to cause to GPs. So that was a significant bonus for us. And we just gave them 4 requirements, I say just. So in our GP systems, users can enter SNOMED CT terms. So for any structured data entry, they can pick from any of the clinical areas within SNOMED CT. Data exchange between systems, so our GP to GP patient transfer records had to be done in SNOMED for the clinical data. They had to be able to take national specifications. So for example, our flu vaccines, we specify who is eligible to a free flu vaccine under the NHS, and they were going to be in SNOMED, and so the system had to be able to support them. And other organisations had to be able to extract data in SNOMED. So for example, we do a number of extracts nationally, but also for things like population health. We had 2 main work streams. Communications was a really strong one. We did a huge amount of communications and training. So, and actually the organisation that does the contracting of GPs, which is NHS England, actually stood up alongside us in the first workshops that we did and said, this is now in your contracts. You need to get yourselves ready to be able to do SNOMED. They also insisted that every region had a SNOMED lead appointed. But we then did lots of online presentations. At one point, we were doing them every week. We did face-to-face workshops for those doing data analytics. We did workshops for what we call subsidiary suppliers, so not the main EPRs, but the other ones. And actually, we provide an update literally every month, even if we didn't have much to say on where things were at. We also showed the GP system. So when they had some functionality developed in SNOMED that was a conversion from the read functionality, we also assured aspects of their systems. Quite lightweight, evidence-based. We split the functionality into what we call bundles and said, these are the things we expect you to do. This is the evidence that we want you to provide. And as I say, we worked really, really closely with them. And we also did first of type testing. So before any of the solutions went live, we had a number of GP practices who agreed to run first of type testing for us. We've produced a significant number of resources. Probably the key one is the mapping tables. So we provided all our suppliers with, if they were a Read version 2 based solution, we provided the maps from Read version 2 to SNOMED. And if they were the CTV3 based solution, we provided the maps from CTV3 to SNOMED. All our presentations were recorded, so people could listen to them whenever they wanted. And actually, all the slides we did, we provided for free. So other training organisations could take our slides, could adapt them, And we have something in the UK called the Open Government Licence. So it's like an open source. Literally all our materials we provided for free. We provided checklists to the regional SNOMED leads as to what they should be doing and how they should be getting all their practices ready in their areas. And we split our presentations around the types of tasks that people were doing. It's probably worthwhile saying, although we provided online training to literally hundreds of people, we've got something like 7,000 GP practices, each employing a number of people. We did not, I'm pretty sure we did not train or provide training to everybody. Some people just took that because they could use Read, they'd be able to use SNOMED, and in a lot of cases they transitioned with little effort at all. But obviously those writing queries and those writing data warehouses, there was now a significant change in how that would work, and that's probably where a lot of our training went. And we provided fact sheets, guides, leaflets, etc., etc. Again, all downloadable, all free, and other organisations could pick them up and use them. So we had lots of balls to juggle along the way and lots of challenges. I've mentioned our payment system. Some people might have heard of it. It's called QOF, the Quality Outcomes Framework. And a decision that this team took was that they literally would move to SNOMED for a particular financial year, which we published well in advance. All the suppliers originally agreed their systems would be transitioned by that date. And as they got into developing the queries that they needed to do to be able to do the data extracts and then work out the payment based on that, it became very clear that once they'd moved to SNOMED, they couldn't transition this back to Read. And due to supplier delays, then QOF was implemented in SNOMED before the systems had actually changed. So we in our team did quite a lot of work to publish the guidance in a Read equivalent, which basically made it really clear to the suppliers we would do that for 1 year only. And if they were delayed any longer, then the responsibility of that fell to them. The mapping tables that we had been in existence for quite a while. We'd been maintaining them. And before we used them to finally transition the data, we actually did a significant amount of QA. We looked at things like rare diseases, cancers. So we looked at clinical importance as well as how often particular codes were used. All the suppliers worked with us and did some stats of the data in their database. So they told us, you know, we could work out which were the most frequently used Read codes, and we made sure literally by clinicians hand looking at those that they mapped correctly. We did quite a lot of changes as part of the QA, and luckily when we went live, there were a tiny number of errors that were found. We'd always warned, and suppliers knew that we would inevitably find them. And so we did the transition in such a way that we could correct those errors. So we ran something that we called dual coding. We kept the original code so that we could remap everything. SNOMED is substantially larger than the existing terminologies that we had, and one supplier had to actually do quite a bit of redevelopment to actually change the way that users actually looked up the terms within the system, because SNOMED offered a bigger challenge. But so that they actually had to change one of the technologies that they use for their browser software. But that's now done and is all working. Our other challenge was we started the training. As soon as we started publishing, you are going over to SNOMED, we started the training, because people kept saying, you know, if you're going to move us to SNOMED in 2 years' time, you've got to train us. It actually took longer than that. And so we had to keep redoing some of the training that we'd done, which was a bit of a challenge. But nevertheless, we actually got there. So I think all our suppliers have been over onto SNOMED, meeting our requirements for well over 12 months now. One of the big attractions was we did have some issues with our read codes. We'd started to run out of places for the codes to go in the right place. And SNOMED actually had much more content in it. So some of our GPs, they were getting information from secondary care and having to record it at a higher level, and they didn't particularly like doing that. They felt they could code things much more accurately. I guess our biggest, the hardest thing I had to do was to stand up in front of a group of people who wrote, designed forms and wrote queries, and tell them that we could not automatically convert any of their templates, their decision support tools, all their queries, because although we tried, we could map from read to SNOMED, the logical structure was quite different, and we could illustrate it was a clinical risk to be able to convert that. So I had to stand there and tell everybody, you know, you might have spent the last 20 years slowly building up all your rules, but you're going to have to look at them, review them, and convert them by hand. I think one of the things that helped me is when I was asking organisations what did they do when they got an update to read codes, it became clear that some people realised they'd been running searches for 5 years and never reviewed whether it was still accurate. And we actually worked with some organisations where we illustrated to them that actually their current searches were wrong. It was often a code that wasn't very often used, but it had been missed out of one of their searches. And they all felt that SNOMED CT was so much easier and to use. It took substantially longer than suppliers estimated. I think it probably took a year longer than they thought it was going to take. But as I said earlier, the fact that the RCGP and the BMA supported us all the way through was absolutely critical. And I think the other thing is that the issues we resolved collaboratively. None of the GP suppliers felt it was their individual organisational risk. We worked out what we thought was the way to do it. We took it to the professional body and said that this is how we were going to do it. Could they think of any issues? And so it became a collaborative decision across all those organisations. So it's a bit difficult to say what functionality have we got in the same way that David did, because basically our EPR is anything that the GP wishes to record, whether it's an intervention undertaken, somebody's symptoms, whether they've done an assessment outcome score, all that is captured within the system within SNOMED, because these are SNOMED enabled systems. RE referrals, so if I'm a GP and I'm referring on to another service, I can look up which providers provide, for example, if I need a patient to have an appendectomy, I can search that up using SNOMED. So, and when I pass on the referral, as I say, that makes use of SNOMED CT. Our e-prescribing, our drugs are all captured in our drug extension. And we have something called a summary care record. So we undertake an extract from the GP record that is available nationally, for example, to emergency departments, to secondary care, and anything that is a disorder or a piece of information that is felt is critical that emergency department should know about. That extraction is done based on SNOMED codes. So we issue a national subset for summary care record, and if those codes are anywhere in that patient's record, that data gets pulled up onto the summary care record. I've already mentioned that our quality outcomes framework is, our payment system is based, the queries are in SNOMED. And there's a number of regions now doing population health monitoring, and they're getting SNOMED data from secondary care, from mental health, and from general practice. Locally, things like drug contraindications, local searches, and actually there's quite a lot of local business rules. So for example, I know one of the, well, I think nearly all the suppliers now, if you are entering data, there's like some software agents in the background, and it might alert you to actually, this looks like early signs of sepsis. You need to take some more observations to either outrule that or confirm. So there are quite a lot of things to ensure that GPs conform to our NICE guidelines, etc. And they're all built on SNOMED CT. And I know Charles is on the call. One of the things that we've both found, and I've spoken to a number of CCIOs who've said the same thing, for quite a while, we've all been pushing people to use SNOMED and explaining the benefits that you can get from that. I think COVID turned things around. We were actually getting people saying it's critical we all record in a standardized way. We need to know ethnicity, symptoms. You know, we absolutely need this to tell me how do I record it accurately in SNOMED CT. And we actually, through our professional bodies, published codes or the terms that were relevant for COVID. We obviously produced some additional terms, but people absolutely wanted to know, how do I record this information accurately, consistently, in a structured way within the system? We had something called the shielded patient list. So these were patients who were actually written to and told they were vulnerable because of their health conditions. And those health conditions and that list was calculated using SNOMED CT definitions and query specifications. We know a number of areas. So I know Oxford has hit the press, Barts Health have done quite a lot of research. They pulled the data together from a number of sources and benefited from the GP data and the secondary care data being captured in SNOMED. During the pandemic, we've been issuing monthly releases of our SNOMED, so we absolutely have been making sure that the COVID terms we need in our systems, we're really rapid in our turnaround, so we add them to our UK release. And one of the projects that I got brought back to lead was all our lab test results. So all the COVID lab test results, we collated them all through a central system that already collected lab results, and we actually produced messages for all our 4 GP system suppliers with all those lab test results in SNOMED, so that they could rapidly, literally the day the result went to an individual, it also went into their GP record, so that if they were to phone up or if they were to get in touch with their GPs, the GP also had their lab test result in front of them in the same way that the patient had. And all that was done in SNOMED, and the lab test results are stored in SNOMED within the GP systems. And that is my last slide. So Ian, do you want me to stop sharing and pass back to you?
Yes, that would be absolutely marvelous. So thank you, Denise. I think it's interesting. It's interesting for me, one, because I used to work in primary care in England, but also most of you know, I think, but I'm the customer relations lead for Europe, and certainly within European countries, specifically, we get a lot of interest in the way that England has followed the mandation route for SNOMED, and certainly the successes and the lessons learned, so they haven't all been successes, as Denise has said, is definitely of interest. So we have a few questions, mainly from my my colleague, Dr. Guthridge. I don't mind reading the questions, Charles, or do you want to ask them yourself? The choice is yours.
I'm very happy to ask them if you'd rather, Ian.
I
It
don't
might
know.
make it more interesting for our audience, I guess. So I put them in case I couldn't remember what each speaker was talking through. But if I could start with David Rocha, I think the information that you gave around tracking of COPD in San Antonio was very interesting. But I was one of the things that I was pondering, because I've spent a fair amount of time thinking about that in East London, where there are incentives for capturing smoking information at a national and a local level. I wondered whether you could link your COPD data to smoking history and or air pollution measures in Texas.
So yes, we are linking to smoking history. The air pollution's been a little tougher. I don't think we probably have to improve that.
Yeah.
So.
And smoking's recorded as SNOMED terms as well?
Correct. Yes.
Yeah. I don't know what your South Asian population is like in Texas, but one of the things that we very much liked about SNOMED in trying to capture tobacco use was being able to record chewing of pan and also oral tobacco, which there are SNOMED terms, and at least something like 30 to 40%, particularly of the women in East London, chew pan, which is a mixture of tobacco and herbs and spices and so on, and is a predictor for poor outcomes in pregnancy. So I wondered if you had any pan chewers and what you do about them.
I don't think we've encountered as many, so I don't think I can answer that one.
Okay. And a sort of broader question, which I think you hinted at, but it wasn't really clear to me, is how you approach practice-based analytics. Is that done in each individual practice, or is it done by the accountable care organization on behalf of each practice?
We do a combination. So yes, we do practice-based, and there's also, like, for each, what I would say, each individual contract. Yes.
One of the things that perhaps the two speakers could think about, I think, which is if you compare and contrast what's happening in that ACO in Texas with what's happening in primary care in the UK, or in England rather than the UK, do you think there are overlaps, or do you think there are more dissimilarities than similarities from what you've both heard from each other?
So this is Denise. So I must admit, having prepared my slides, I would struggle to say, but then I work from the centre, to say we use and give specific examples, because in general practice, I think within England, we now use SNOMED for everything. So what, we don't have focus on particular clinical areas. It's probably worthwhile saying alongside that, though, because we record everything in SNOMED, we do have regional data quality leads. So I guess by focusing on things and saying very specifically, this is how you're going to record, then your level of data quality is quite high, because our GPs can pick from anywhere within the SNOMED. And although we've got nice guidelines that give some indication of what we need to record, we do have, every region has to have a data quality lead, and we do keep an eye on the data that's recorded, because we are aware that GPs don't always pick the right terms.
Do any of the systems use constrained lists, or is there absolutely free access to use anything they like?
So if a practice has produced a template, and there are templates for things like weight, height, asthma reviews, then they're constrained lists. But in all of our GP systems, if you don't know what the patient's going to walk through the door with, if you do just a straight journal entry, so you're not complete, you're not doing a vaccination or something that you know what it is that's coming through the door because they've been called for an appointment, then actually you can pick anywhere from within SNOMED.
And do you think they come across the problem that I sometimes see in secondary care, which is in East London, which is that because essentially you can use any code from any hierarchy, more or less, within our system, you find procedures listed as a finding in clinical findings, or a finding listed as a procedure, and those kind of issues. It's easy at the point of care because human beings are rather good at interpreting that, but obviously when you start to think about population aggregation, that's quite difficult. And certainly if you were to use some of the higher features or the descriptive logic features in SNOMED, then of course you get very puzzling results if you start to have procedures in a findings list and so on. What happens in primary care?
Let me break in. It would be so easy if in the systems they had something and says, I am looking for, and then it could say an infectious disease, and then it could have various systems like respiratory lung disease, or central nervous system disease. And if you could then cut, so everything that in the disease would have to be a disease or a finding. So that would be the first part of the query. It would go to the terminology server, and it would say it has to be a disease, it has to have finding site lung, and it has to be infectious, have a causative agent. That alone would put you in a much smaller universe of only right answers.
Yeah, I agree with you.
But I think, Charles, within general practice, I mean, if you've looked at some of the systems, when you put in your journal entry and it's much more like predictive text, you don't sit down and say, I want an infectious disease. And our GPs just would not accept that. We struggled with that in mental health. It just, any suggestion that you have got a dialogue with the terminology and you're slowing down data entry absolutely goes down like a lead balloon. So, the other challenge we found is, and every time I come across one, I put in a request for new terms to be authored. But there are times where we've done interventions and the only thing that we can find that anywhere is like it is still a finding. So, so I think it was diazepam monitoring. Then, to our mental health people, they believe that that's something that they're doing, but in SNOMED, it's actually a finding. So one of the things that we had to do in the mental health side of things is be much more liberal about which hierarchy would we allow the data to come from for our procedure extraction.
Yeah. One of the things Peter and I guess, have been wrestling with quite a long time now is trying to demonstrate how descriptive logic works and how the compositional grammar and expression constraints language work and how they might be used for analytics. Are you beginning to see sort of IT smart GPs asking those kind of questions and saying, how could I exploit this for, I don't know, a research project or an audit project, or do you think that's still some way off?
So in one of the GP systems, you can actually put ECL into the query functionality.
No, so really?
Yeah. And the reason that I think they provided that is so our, as you know, our QOF surgery is actually.
You might say what QOF is, Denise.
Yes, so it's used as payment, but it defines it defines particular clinical groups, and often it's to encourage quality treatment. So every year our contracting team will decide with what they want to put payment in for. So for example, it'll be that you've had a asthma review. All your asthma patients, at least 95% of them have all had an asthma review in the last 12 months. And the way that we do that is all the specifications are written in SNOMED. They're all written in ECL and they're all published in ECL. So we know that some practices take that ECL and they actually then build their own queries into their own system for it. And when I did all the training for the move over to GP practice, we absolutely did train and produce webinars on writing ECL and how to write queries.
Wow. David, are you teaching a primary care physician in San Antonio how to do an ECL query?
No, not yet. So,
do you think it's coming?
I hope so.
Yeah, great. Well, I've been hogging the floor, so I'm going to let Ian ask a question or two.
So thanks for dropping that one on me, Charles. So I'm genuinely interested because this has come up somewhere else, or a similar question. So one to Denise. So the read to SNOMED maps, you obviously need to maintain as SNOMED changes. How long do you think, one, you'll keep maintaining them, and how long do you think they'll continue to be useful?
So we don't maintain them anymore. We declared that after the April 2020, we wouldn't maintain them. So they're not maintained anymore. And that was the reason we kept maintaining them, was in case we found errors. And as I say, given the fact that the whole of our quality outcomes framework, which is quite extensive, is published in SNOMED, the amount of errors we found were really quite small in comparison with how many maps there are. We in GP systems, we already go beyond, although they've got a more constrained subset of SNOMED, they don't always, I'm not sure, in fact, because I've been retired for over 6 months now, I'm not quite sure where things are at, but they didn't always use the full amount of SNOMED. But we don't maintain those maps anymore. We'd still publish them so that if people are doing research and come across recodes, they can find them, but we don't maintain the maps any longer.
Okay. So we have the same challenge with some of our deprecated maps, which is why I'm genuinely interested in the question. So there's been a lot of publicity with the UK, England, taking a national terminology server. So Onto server from Cesaro down in Australia. What opportunities do you think that brings that you didn't have previously?
So
question.
So the challenge has always been for us that if the suppliers are SMEs, and by an SME I mean a small to medium size enterprise, but even then they can still employ up to about 250 employees. Previously, in some of our domains like mental health, all they've ever had is keyword lists. They've not had anything like read like the GP suppliers did. And those keyword lists, have probably are just managed lists and have probably a few hundred terms in them. So the prospect of going to SNOMED has been a major challenge for them. And there's one supplier that I've been talking to for quite a few years, and all they kept saying was, we desperately need a terminology server. There is a lot of the functionality of their system they buy in through modules from other suppliers anyway. And they always were of the view that they weren't going to develop the terminology capability themselves. They were always going to use a terminology server. And I think the challenge for them was actually coming up with a supplier who would provide that service to them. So now we've got the terminology server and we've put a framework contract in place so that they can either have a hosted version, so they don't even host it on their system, or they can actually buy one and host it themselves. I think we'll move, well, I'm hoping we'll move some suppliers who've been really reluctant to what I class as properly implement SNOMED. What some of them have done is say, here's SNOMED, and you can, what you've got as your key word list, you can tag SNOMED alongside it, so that if you have to send your data out, you can send it in SNOMED, but inside the system, you're in effect still working with a very restricted keyword list, which means for some of the things that we want to do, it's just not going to be expandable. And I think the terminology server, I'm hoping, will change that.
So exciting times.
Hopefully.
Can I ask one last question to the two speakers, which is something which I think is quite puzzling and is about interoperability and the ability to exchange data across different systems and so on. So in the US, as I believe it, and David, correct me if I'm talking absolute rubbish, but I think that's been defined by the ONC as a set of rules which are maybe incentivized, but even if they're not, they're rules, and which are maybe driven by patient preference and patient demand. In the UK, we have a slightly different approach, I think, which is that there are kind of national standards published and which you are supposed to use, but there are no consequences if you don't, and no consequences if people kind of do their own thing. I'd like you both to give me a view as to whether the question of the ability to particularly exchange data between the primary and secondary care interfaces is on a useful and developmental journey at the moment, or whether you think it's stuck in either in your in your different countries.
David, do you want to go first?
Sure, I can go first. So I would say it's more developmental based on what you were mentioning. And then I know with the ONC, they use different terminologies for some of the different items. I know that the ONC is considering of using more FHIR for the future. So that's why I'm hoping that they won't forget about the importance of SNOMED too, because to me, you can't have one without the other. So.
Yeah. And where do you think we are, Denise?
So I think so I'm hopeful that, only because I've sort of been researching it for the last month, there is a big push on what we call that transfer of care project.
Yeah.
And as far as I know, we've already got some pilot sites. So I'm hopeful that will start again. I know NHS England have backed off slightly because of COVID, because we didn't want to put organisations. So a lot of the things that were in train to happen this year, NHS England and NHSX have backed off for, because obviously it's just not realistic to expect organisations to do that. But I'm told that transfer of care already has some pilot sites and is moving. The challenge, like David just said, is we will be using FHIR in England.
Except the wrong version of it.
Oh, I don't know. and that was the challenge for our GP practices, because they'd already implemented for a transfer of care, but in HL7 version 3, nobody from secondary care had ever sent anything. So they'd all done a lot of development work which had never been used. So you can understand that they are very reticent to say, okay, we'll now develop FHIR, because there was, well, we can undo, but are you really sure you're not going to change it yet again, and we're going to do this and not get any data sent to us? So but I do think we're getting closer. That my worry, and a number of us have had this for a while, is that general practice absolutely is only pre-coordinated. And I know some of the secondary care systems have gone down the route of post-coordination for some data. So I have a worry about how we will do it when it comes to it. I think it might take more work than people initially think at the moment because of the pre and the post-coordination issues.
Yeah. Fantastically interesting stuff. So thank you very much, both of you. I'm sort of optimistic, but not. I mean, your last comment about, you know, NHS England and NHS X and D have sort of chickened out in driving the standards use and defining ISNs and so on. At the same time that they've pulled off that, they're also saying you must do remote consultation, you must do video consultation, you must provide services to patients who are still at home and so on. All of that depends on FHIR, interoperable messaging, use of standards, and it just seems completely contradictory to be issuing orders from NHS England on the things you must do from a sort of human comprehensibility sense, with no genuine backup in the IT sector. I think at the moment, I think the IT bit's a bit incoherent personally, but that's a personal view, which I'm probably shouldn't be heard by the Department of Health at the moment.
There have been some other issues as well, Charles. So you probably know that we've got the Professional Record Keeping Standards Body.
Yeah.
And they issue.
I may have invented it.
And they published a number of standards. So a couple of years ago, I started working on the mental health side of things, because obviously every domain we're trying to get over to SNOMED. And one of the challenges we had is that there was conflict between the FHIR standard, the professional standard record keeping body, and actually it had not been updated, but I think NHS England had published a discharge for mental health, and we had our data dictionary, and I sat down with one supplier and he went, well, it would help if all these four told me the same thing, which one am I? And they don't.
I know.
So I have raised that, and I had a call with PRSB a couple of weeks ago, and we're hopeful that we're resolving that. So I think things like that have not helped, because, you know, suppliers are reluctant, if it's not really clear, to make a judgment for themselves, because sometimes 6 months later they're told they did it wrong and then they've wasted all their development. So I think some of those things are getting ironed out, but as you well know, there are lots of organisations involved, and trying to get things like that dealt with has been quite hard.
Yeah, I agree.
I think it's disappointing that what David has done in his practice is so not widespread, and we don't know. It's such an obvious thing to do, and you know, the major Epic and Cerner and stuff don't do like that. It's a shame, after so many years of knowing about David, that I still don't know anybody else who's done a similar thing.
Yeah. Yeah,
I mean, what could SNOMED do to get people to realize that how doable this is and how valuable this is?
We could try cloning David.
Well, he could start a company, but the real way in, though, is through Epic and Cerner and the big vendors, I think, because that nobody's going to do it themselves like David. It's just, you know, nobody's going to take that time and initiative. It has to be done at the product level and come packaged.
Yeah.
So Peter, I think you're right. I think, though, one of the things. So Denise, you can either agree with me or disagree with me. I think it's interesting around the Cerners and the Epics and the big ones for secondary care, definitely. But within the primary care market is an interesting one, because you tend to get more, I'll call them nationally focused suppliers and smaller suppliers. And certainly not so much in the UK, but certainly around Europe, there are a lot of startup companies which are looking to get into the primary care market and are looking to, I suppose, differentiate themselves from their competitors by starting to use some of the advanced functionality, I'll call it, in SNOMED to deliver benefit and show how that can be done. And the market tends to be a bit more flexible, where secondary care tends to be a bit more monolithic and slow to change. But
And
feel free to disagree with me.
yeah, well, I think that we have, in our new definition of level 1, 2, and 3, David is getting his functionality at level 1, and we should really give some of his concrete examples that he presented here in that paper that we're supposed to be giving, that hopefully vendors will see.
Yes, I agree. Okay, well, I think we've managed to get through all of your questions, Charles. So personally, I'd like to thank both presenters. I will let you both know how many downloads we get of this, but to give you some idea, we had just over 300 downloads when we ran the clinical session over the expo. As Charles is on, so Charles did a clinical webinar a couple of months ago, and we had just over 100 downloads for that. And I think the smallest number of downloads we've ever had was 80. So I will let you know, but don't be put off by the attendees. It's more about people really accessing the information after. But I'll let you know for Christmas. There you go.
Thank you.
So on that note, I'm going to bring this webinar to a close. So I'd like to thank you all and wish you all a happy Christmas and a happy New Year.
And to you, thank you very much.
And may 2021.
Thanks, David.
See you. Thanks, Denise and David.
May 2021 bring you all the SNOMED implementations you could ever wish for.
Please.
And a few gins with it.
Live in hope. Right, take care, everyone. Bye now. Bye.
Bye.
Bye.